All right. Well, hey, Gerry, thank you for joining us today.
Nice to be here.
We're with Gerry Brogan from Northwell, and you just gave a talk not too long ago.
Yeah,
so sorry to keep you in the hot seat, right?
No, it's okay.
Some of our folks were able to attend your talk, and so I got some insight. I got some notes.
But I'm impressed they stayed awake.
It's
you know,
especially late in the day, right? That's the challenge.
It was right after lunch. So,
you got to hand out like dark chocolate when you speak it.
Totally.
Well, just in getting to know you right now, it's fair to say it's not every day that you meet a veteran ER physician that becomes a chief revenue officer. But it sounds like you spent a lot of time in the trenches with your staff at 4 in the morning when there weren't patients, trying to help and listen and learn. And at some point you decided, well, maybe I'll go do the business side of this for a while.
Yeah, I actually never planned on doing this.
Yeah.
And I was telling somebody the story, and my daughter was near me. She was like 8. And I was saying how I started emergency medicine, working in the trauma center, doing research. And, my plan was never to be in business side of medicine, never to wear a suit to work.
Yeah.
And as I'm telling this story about how I wound up here, my daughter just turns around and says, so basically you're a failure. And I said, well, I never thought of it that way. But actually, so it's not typical. But what got me into it was as I progressed in my career and took on administrative roles like running ERs while still working clinically,
Sure.
I started seeing that I was in hospitals that were losing money or not making much money, and you couldn't invest in right staffing, you couldn't get new equipment. And so I started just getting interested in understanding how we were paid or why we weren't making money, really just in order to help the hospital make money so we could deliver better care. So it was always really about just how to take care of patients better.
Yeah.
And then as you learned what were the issues, you had to get involved in fixing them.
Yeah.
And then you started getting asked to, chair a committee, be the medical director of a hospital, be the CEO of a hospital, and then it just kind of continued on.
Sure.
And I was then the medical director of revenue operations, working for the chief revenue officer, really working on more the middle revenue cycle, clinical documentation, getting the doctors engaged, getting them to understand why you have to call something this word so it can be coded versus another.
That's right.
And then I got asked to do this role. And I had done ER now for 28 years. I was starting, it was like twice the normal career of an ER doc. So I said, you know what? This might be interesting to do as opposed to retiring. I didn't have my 403B wasn't where it needed to be to retire, so I said, let's take advantage of the opportunity.
Yeah. Well, what a gift for somebody that was in the trenches and spent that time in the middle of the night trying to understand, how to help. And you clearly bring a unique perspective, right?
Yeah.
It's.
Well, when they were trying to figure out, why we're getting bad insurance information in the ER.
Yeah.
And I said, have you ever been in the ER at 4 o'clock in the morning?
Yeah.
It's some kid or some mom that's on her second job that's sitting there with no patients for, coming in for a half hour, falling asleep, then somebody shows up. They're in congestive heart failure. They can't talk.
Yeah.
They're not producing their insurance cards.
That's right.
And they get done what they need to get done, so a chart comes out of the matrix dot printer.
Yeah.
So you can start caring for a patient. That's the priority.
Yeah.
Until we change the staffing, the technology, we're not going to get better information.
Sure.
So if you don't understand what's really happening, you're not quite sure what resources to throw at the problem to try to fix it. And then also how to recognize these folks, So it was kind of nice to give the staff that credit for trying to do a great job despite those. And when you finally started giving them better training, a printer that didn't jam all the time, they were just thrilled.
Yeah.
And then they got engaged. And then, you know what, they really made that extra effort to say, oh, do check your wallet for the card or this or that. They were that much nicer to the families. I'm sorry to have to get this information, but it's how we make a chart. I know you're not feeling well. When you believe in them, then they're willing to carry out your mission.
Sure.
And so, but they got to know that
it's the personal
it's
touch.
real. Yeah.
Yeah.
It's just how do you want to be treated in any role?
Absolutely.
It's that simple. So.
Yeah. So this series, RCM Innovations, right? One of the things that we're talking about as a theme is, a couple of years ago, HFMA had a study. We talk about $1 trillion in waste in healthcare, but in the revenue cycle, it was $266 billion.
Yeah.
So no one knows more than you that can we take that $266 billion and get efficient so we direct that more to the patient, right? So how do you guys think about that? Like, what do you want to do to tackle administrative waste so hopefully those dollars get shifted more towards clinical innovation, patient care, patient experiences?
Exactly. So that's one of the things that gives us hope in healthcare, is that there is so much waste, and if we actually can address it, we can start putting that money towards prevention or insuring uninsured.
Yeah.
So there's a lot of clinical waste and overutilization, but that's not your question. Your question is in the rev cycle.
Yeah.
So where is there the most waste? For us, it's really on the back end.
Yep.
It's battling with payers over getting paid.
Yep.
And we've tried to do some innovative things where we work with one payer to say, look, at the end of a year and a half of fighting, for these 1,000 discharges, you wind up paying me X amount of money.
Yep.
But I spent $4 million fighting for those dollars, and you spent $4 million trying to keep me from getting those dollars.
Yep.
What if we just agree on a new blended rate for these shorter stay cases that you like to deny, and you just pay me immediately?
Yeah.
But we don't have to go and argue about it. And so we did that as a trial. And we wound up with the same revenue. They wound up spending the same amount of money to pay us. We literally saved $4.3 million.
That's fantastic.
That was pure waste.
That's one of the most discrete examples that I've heard.
Yeah.
There's a concept that we call it détente. We try to bring payers and providers together through our solutions
an interesting way
through
of putting it.
détente. And that's one of the most discrete examples that I've heard.
Yeah.
Because you're right, it always ends up being the same number, but how many touches had you not done that?
Right. And 18 months later.
18 months later, many touches.
Yeah. Now the payers would still like it to be 18 months because they're sitting on that cash for 18 months.
Yep.
So they were a little reluctant to pay us up front, but we said, listen, we really think these were full-blown admissions. You want to pay me less than the DRG, so at least you got to pay me. Yeah. I spent the money. I paid my nurses. I paid the pharmaceutical company because of the drugs I use. At least pay me the money. When have you gone to a restaurant? 18 months later, you mail in a check to the restaurant.
Well, and I think we both understand some of the reason why, because I understand from the notes. I use the term hedge fund, and you use the term bank.
Yes.
Payers are really a bank masked as a payer.
Yeah.
And it's. I just think that there's opportunity to bulk batch adjudicate, because while the delay of money, we all know what happens with time value of money, but the cost to collect and the cost to adjudicate, and throwing rocks at each other for 18 months.
Yeah.
And I used to say that it was people, I'm going to call you, you're going to answer, we're going to do this, right? But now it's even the respective bots and claims editing, scrubbers, edits. Some of the technology's arguing, and it doesn't even know that it's arguing.
Yeah.
But the money's still getting delayed.
Yeah. So we have a bot that we developed that actually takes denials. It reads the denial reason. It analyzes our codes. it goes and pulls the source data as to why we coded it correctly, puts a letter together and sends it back to the payer to appeal that denial, all done by a bot. Now, it's great because it's more efficient, but it's kind of like we're avoiding facing the problem of that fighting over coding and things like that.
You're putting a Band-Aid on.
And it's not inexpensive. It saves us some FTEs.
Sure.
There is a little bit of an ROI, that's why we did it. But you don't want to be getting involved in putting technology in place when there's a better solution that you're ignoring because you don't want to find that middle ground or that détente. You know.
So let me ask you this. One of my favorite questions throughout this has been silver linings because of COVID, and from a revenue cycle standpoint. So people started working from home. Many silver linings. Many challenges, but were there any silver linings for you as it related to COVID? You know, from a back office standpoint.
Yes. One was it accelerated our work from home movement. We were starting to do that.
You were already on that point.
But it would have never gotten to the point it is, and never as fast if it wasn't for COVID. And because of our work from home, so we're 20 hospitals, 720 practices, $15 billion. We do 5.5 million encounters a year. So just for revenue cycle, we were in 11 different buildings, 11 different leases. We were now able to shrink down to 3 because of all the people now working from home and our plan to keep working from home. That alone is going to save us $6.8 million per year once every lease expires. So that's $6.8 million in margin. So we can do community programs, we can buy equipment, we can already improve our charity policy, which is already one of the most generous in the country. Again, money that was just not being wasted because we were paying a landlord and that employed somebody and there were people cleaning that space, but someone else is going to pay that rent for some other business. But healthcare doesn't need to do that. Our staff's happier. I think their quality of life is better. So they can be there to put their kid on the bus because they're not spending. And in New York, where we work, commuting is hell. Okay, that's like an hour each way of hell.
Absolutely.
It's not like you're driving 20 minutes through the mountains of West Virginia. You're in hell. And so
opportunity cost.
Avoiding that stress, having people be with their families. Our staff loves it. But I said to my staff, I said, listen, we have to perform as good, if not better. Okay, because that's what we're paid to do. But if you can do that, working from the top of a Ferris wheel somehow, then you know what? I'm going to respect that. And you go do that. And so they understood they had a responsibility. And I'll tell you, they seized the moment, and our metrics improved every year of COVID. All of our, cost to collect, the KPIs, the AR, administrative write-offs, everything improved despite the challenge. And so I think that was a silver lining.
It's great.
It also pushed us to more bots and automation. Because I'll give you an example, claim status bots. That's like probably the most common bot that people start with. Simple stuff, screen scraping, mind-numbing work. When it came time for mandatory vaccination, not one bot refused to be vaccinated. Where we had patients, we had
good way to put
staff that we had to lay off because it was a New York state law. So that was another kind of silver lining where it made us look to automation faster. And I think as we find it harder to source employees, particularly for a lot of these entry-level jobs, we have kids now that they're coming out of college and you offer them a job, but it's kind of this, call center stuff, and they're like, that's not fulfilling. I'm not going to take. I'm like, well, what other offers do you have? Oh, I don't have any other offers. I'm like, wait, you're turning down a job with full benefits just because you don't like it? But this is sort of a generational thing. So I think COVID made us look at these technologies that even when COVID's gone, I think the workforce is going to be harder to recruit for some of these roles that, they're tough roles. But when I was coming out of college, I mean, even in medical school, I was still working at Friendly's.
Sure.
I was scooping ice cream and cleaning the bathroom at the end of the night, just because it was money.
Yeah.
But, you know, the world is changing.
We're in a more digital world, and I think it's more understanding from their perspective.
Yeah.
They do want it, you know, I find it, I mean, I have daughters, you know, so I love to really understand from their perspective, because they can speak, you know, they do want to do meaningful work.
Yeah. It's sincere, it's real.
It is real.
And you know what, it's probably healthier, and it's probably the right thing.
Yeah.
And, you know, my generation, I mean, I'm 62.
Yeah.
My generation was, you know, if someone offered you a job, you said yes.
Yeah.
And then,
me too. Yeah.
You know, that was the end of the discussion.
I worked at KFC when I was 15 and a half.
Yeah. McDonald's was my first job.
Yeah.
And it was one of the greatest jobs to have, because if you learned about operations, standardization, it was a great job.
Cleanliness.
Yeah.
Yeah.
And then I moved to Friendly's, an ice cream place in the Northeast.
Yeah.
And again, teamwork, camaraderie, process flow.
Sure. Some of the fondest memories at those jobs.
Oh, absolutely.
Yeah.
Absolutely. So,
let me ask you this. Let's go out to like 2025. What do you, from an innovation standpoint, you know, market disruption, thinking differently?
Right.
What do you want to get done?
So, looking at a kind of front, middle, back part of revenue cycle.
Sure.
The front part, shocking news. We want to be more digital.
Yep.
More digital friendly for the patient.
Yep.
Prep them better before a visit. Collect all the information.
Yep.
Have them come into the practice, right into the exam room, and there's someone there starting to do something meaningful. Not handing them a 2-year-old magazine of Good Housekeeping.
Exactly.
And say the doctor will be with you at some point in the next.
Or the clipboard.
Oh yeah.
I've given you my information 20 times.
Yeah. So. So obviously not shocking news, not a unique strategy, but we really want to make sure that we move meaningfully down. I think, again, from a generational point of view, a lot of the younger patients want this.
Yeah.
It's how they shop for doctors. It's how they make appointments.
Yeah.
No one dials telephones.
No,
you know, they go on their phone, and if we are not the path of least resistance, if we're not at least as friendly, if they can't shop and find out what we have available in doctors, urgent care, this, that, and the other thing. So on the front end, really make it easier for patients to get care, to get them next to a provider.
Yeah.
Take as many people out of that lineup between them and the eventual doctor or NP or PA.
Yeah.
In the middle space, again, trying to reduce the expense, we're looking at as much computerized coding as we can.
Sure.
Probably 70-75% of the coding in a medical practice you can get done by NLP, robots, etc. So
99283 with an ear pain and a fever.
Yeah. And you know, again, I think it's getting harder to find coders. It's horrible work.
Yeah.
It is amazing to me how good particularly our hospital-based coders are.
Sure.
High school graduates with a coding certificate.
Sure.
Reading complex charts that have evolved in the last 20 years, the complexity of medicine.
Sure.
Specialists of specialists, and yet most coders are generalists, but they somehow can understand a complex neurosurgical procedure, a complex oncologic diagnosis.
Yeah.
So some more computer support for them is going to be critical.
Yeah, NLP, NLU, computer
and then on the back end, you know, bots, RPA, more technology to create a bill, to move a bill out, and again, digitally, to have patients pay the bill, to get the bill digitally. You know, we already have digital payment platforms. You can set up your own payment plan, interest-free. Access consolidated bills on the medical group side. Eventually, you want to get the hospital and the medical group side. That's a big lift. You know, it's harder than people understand. When you've got somebody that went into a hospital, some of the docs took care of them, are faculty, some are voluntaries, some are in network, some are out of network. You know, creating a consolidated statement, I mean, that's a huge lift. Maybe all the faculty docs.
Yeah.
yes, but you've got maybe an anesthesia group that's a different group, voluntaries that staff an OR at one of your hospitals.
Sure.
They don't at another. So how do you have one platform that does consolidated statements with all of those scenarios?
Yeah.
But again, at least if you made everything else easier for the patient, you've eliminated 8 out of 10 pain points.
Yeah.
And you're making progress, So that's kind of how we look at it across the continuum.
Sure.
Lower the cost to collect, improve the experience, eliminate the waste, and then reinvest that in actually taking care of people.
Yeah, absolutely.
So.
Do you think the topic of gamification with back office staff, giving them, whether it's badging or points recognition, non-currency. I mean, I always love it if you can do a little incentive pay and gamification.
No one turns money down.
No one turns money down.
Yeah. So gamification. So I learned that word about a year ago.
Yeah.
I was like, oh, what the hell is this? Another thing I got to learn.
Yeah.
But so I've got an amazing team of vice presidents and assistant VPs and directors.
Sure.
And some of them came from other industries where their entire job was planning parties and doing fun stuff.
Yeah.
And so they have come up with some of the most engaging things to do over a Teams. We generally do Microsoft Teams at our health system.
Sure.
Games, ways they engage the staff.
Sure.
Things I never would have thought of.
Yeah.
I never would have thought of would have sold or gone over.
Yeah.
But just really effective. People love it.
Yeah.
And you've got to, you're kind of bringing up another issue is going forward, what is going to be the skill set of a leader? When you're leading remotely, you got to be a little different. You got to be willing to get silly.
Yeah.
And you got to have far more trust. People have, you're not a leader unless people trust you.
Yeah.
I can tell you that from the military.
Yeah.
Okay, if you're leading 18-year-old kids in Afghanistan, right?
That's right.
If they don't trust you, forget it.
Yeah, you're doomed.
Same thing in healthcare. And when you're remote, what I tell people is working from home and being remote does two things. It allows you to capitalize on your strengths, whatever you've done, trust, leadership, and it exposes your weaknesses like a spotlight on a cockroach.
Yeah. It's a good way to put it.
Yeah. So, so the gamification, if you asked me years ago, I would have been, it's cute, but
it's cute,
But I'll tell you,
I had the same reaction, and but then I also had to confess that when my Apple Watch gives me an attaboy for doing 10,000 steps, I'm not going to lie, that's kind of, hey, thank you.
Yeah. We're social creatures, and any social interaction creates biochemical changes in your body that are positive, even if it's coming from a machine.
Yeah.
We like to be validated.
Yeah, sure.
We're not designed to be solitary creatures.
That's right.
And that's just Psych 101.
Yeah.
And Rev Cycle, unfortunately, you spend a lot of time in front of a screen. It could be a solitary existence for a lot of your day,
Yeah, just having some breaks in the action and, it's having some banter with your colleagues. If you get badges and points, and you can say hey, I collected more 10 accounts more than you did today.
Yeah.
And I got an attaboy or an attagirl, that's fun.
Yeah. And, for some staff, it totally wows them. Some are like, it's cute.
Yeah.
But I'll tell you, you got to do it. You can never, generally, when I look back at sort of my failures as a leader, one of the more common things was I spent more time with the bad performers trying to make them better than I did complimenting and rewarding the good ones.
Yeah, sure.
And I've totally changed that now, where we try to exit the bad people quickly, and I make sure that I am continually rounding with my staff, telling them what a great job they're doing. And we went from with engagement scores, we use a vendor, there's tiers, 1, 2, and 3. 1's the highest. Traditionally, a Rev Cycle staff is, high tier 3 maybe. We got up to tier 1 and even improved further during the remote work, during COVID.
Oh, wow.
Because of recognizing people who historically hadn't been recognized.
Yeah.
And now when you're talking to somebody who had to assemble a chart, and you say to them, look, I understand, wow, you have 14 different systems you have to go in to actually create a medical record.
That's right.
They're like, you know that? I'm like, well, I wanted to understand what you do. And they're like, wow, yeah, you know. And then we talk about, so how can we make this better? And I constantly go to my staff, if you had a blank check and could fix the thing that just pisses you off the most, what would the first thing you would do? And then we say, all right, let's see what we can do there. Can we do it all? Can we do part of it? Can we at least put it on the plan that we're going to, you know, improve something about that experience? And, you know, you do that for people. It's monumental. Yeah, I think, you know, part of what you're tapping into is also the notion of how important EQ and soft skills are, right? Yeah. It's so important now to understand all that nuance, spend time, listen, because I think, you know, when you have a topic like innovation, it's easy to think about bits and bytes and, you know, tech buzzwords, and but it is fundamentally about people and how do you let them flow? We love the word flow. Like, you got to let people flow. And you do have to find ways to remove the friction and incent them in ways and create a fun place to work. Right? And even if you bring in tech, so we've been on a mission the last 3 years called Back to Baseline to really double and then triple our margin, which we more than doubled the margin in 2 years. That's impressive. At the time was $11 billion health system. And we looked at sort of the people, the process, and technology. Now, the problem with technology was that by the time you investigate it, plan it, dedicate capital, et cetera, we haven't implemented one damn thing yet. But we accomplished more than doubling our margin because number one was people. Did we have the right number? Did we train them properly? And once we trained them, we said, now we're going to hold you accountable, but we're going to reward you. And engagement went up. So we made them work harder, we had tighter metrics, and they were happier because they were recognized. We also did a lot of operational stuff where we said, we're going to take this stupid stuff out of your job. You know, and putting it in that way too is refreshing to them. So I walked around and I literally sat with people. I said, so I want to see you pre-registration. I want to see, and like they're working on this little computer screen and they're toggling between 5 different applications. I said, do you do this every day? You have to go in and out? I said, this is insanity. Ordered two screens bigger. And I said, so, you know, now you can do a split screen. So now you can have 4 things up at one time. They were like, and I just said, we have to improve the operations. And when you do that to people, what you're saying to them is, I want you to work better. I want you to be better at your job, but I'm willing to make you have the tools so you can do it. Absolutely. Now we're finally getting technology. So to me, technology should be just that extra juice on top of an already engaged workforce where you have optimal operations, and now you're just going to turbocharge it with tech. And you know, that's sort of how we did it. Not so much intentional, but it was just we couldn't get any tech up and running in faster than the last 2.5 years. But I agree with you that, you know, ultimately humans use the tech. They got to interpret the tech. You got to train them. You know, it's not tech. Tech alone is not going to do anything for you. But when you have all 3 legs of the stool, the people, optimal process, and then technology that's optimizing those first 2 legs, that's when you really hum. You know. I also think that, you know, when they feel like you're making them more marketable, it's like, we need to train you and give you great skills. Right? Some people say, well, then they're going to go get another job. And I said, no, then you got to work on loyalty. So the best way to build loyalty with them is to give them great skills. Right? So this notion of upskilling people to like more knowledge workers. It's very doable. It's all there on the table. Oh, absolutely. It's hard work. You know. The hardest job we have recruiting for is our financial services, our call center, because they get calls, and usually people are not calling in because they're having a good day and they just want to share it, you know. But they also have to work in a number of different systems. We have 7 different financial operating systems, depending on what hospital it is.
Sure.
Because we acquired a bunch of hospitals, and So, but what we tell the staff, I said, listen, you need to give us 2 years in this role, because it takes like 4 months to train them. But if you do, you know more about revenue cycle than any starting job in this health system, and we will then place you. We will then promote you. We know this isn't what you want to do for the rest of your career. And that's what we've been doing. And people stay. Now, some do leave because it's just not the job for them.
Sure.
And we even help them. If they came, they gave it a good try, and they, it's not their
reality,
fault.
sure.
It's just reality. And you don't want them on the phone with the patient.
Sure, yeah.
But you do learn a lot, and we do make it really clear that there's a career path, that we understand. I tell my staff, this isn't the first job I ever had, and I know this isn't your intention to be the last job that you have. Yeah. So we will grow you. That's what we want to do. And I'm a big believer of hiring from within. As long as you got the right talent, you've got to reward the loyalty. And my staff knows it.
Absolutely.
My staff knows it. They've seen me turn down some really good candidates just because I had someone internally that I know was waiting for years for a role, and I'm not going to disappoint them. And I know they'll work hard for me, and they'll do as good a job as the outside person.
Absolutely. I couldn't agree more. I say, somebody that's hiring somebody to fill a size 10 shoe. We use that analogy. If you got somebody that's at an 8, just throw them in. Yeah. Because then that loyalty, you can't put a you can't put a price on that loyalty. Yeah.
And you have the right person who's intelligent enough with the right effort, dedication. They are driven to succeed. You can almost give them any job, and they'll do well. Yeah. Because most of what we all know here, no one really went to college for probably 90% of what they're doing in this showroom right now. It was all learned on the job because they were interested, they cared, and they just wanted to excel.
Yeah.
So
absolutely.
Yeah.
Well, in our remaining minutes, we're getting the wind down. What's one question that I didn't ask you that I should ask you?
I think going forward, in a broader healthcare perspective, we are going to have to address healthcare spend in a really serious, fundamentally changing way. I think true population health, true accepting risk, true controlling utilization, and with that's going to be different payment methods. There's going to be different revenue cycle issues with that. I think we are coming to a point in healthcare, and I know every year everybody says it's different, it's the worst year, but we're getting to a point where we've got to make more fundamental shifts in how we deliver care. And it's going to take some real leadership. It's going to take cooperation. It's going to take federal, state level stuff. And so I think we have to be open to how do we improve the quality of care still, have greater access for folks that don't have access. Like you mentioned in the beginning, waste. We've got to. The hopeful thing for me is that there's still so much waste.
There's so much.
Thank God, because that's a lever. That's a lever that we can pull.
That is exactly the way to think about it.
And so, I think about that and the reason I think about it is, as I get older, I'm going to be a consumer more and more. But what am I leaving my kids? What kind of health system for my kids and eventual grandkids? So you kind of feel a responsibility to do your part to leave them with something that's decent. So
absolutely. Well, what a perfect way to end. Nobody will argue that. So, hey, Gerry, I just really want to thank you.
Thank you.
Thanks for joining us.
My pleasure. Nice pleasure. Very nice to meet you.
It's been great, and we hope to have you back. We're gonna We're gonna do this at Becker's more than once, and we'll be back in the fall.
Cool.
So it'd be great to have you back on the show, for sure.
My pleasure. Thank you.
We can check in on some of those initiatives.
Yeah, all right. Sounds good.
All right, great. Well, enjoy the rest of the show.
Thank you. You too. Take care.
Appreciate it.
Bye-bye.